Thank you. Welcome everyone to our pre-op testing work group. It's December 2nd. I hope you all had a wonderful Thanksgiving break. My name is Emily Bear and I'm a site engagement coordinator with MVC, and it is my pleasure to be facilitating today's work group with you. So our agenda for today's work group, I'm going to first review just a couple of housekeeping items. Then we will have two presentations for you, one from Nicole Mott of RITE-Size, and then Kelly Lewton from Lake Huron Medical Center. We'll then follow that up with some discussion and Q&A, and then review a couple of MVC updates and upcoming events. All right, so before I introduce our presenters a little bit more, just a few housekeeping items. First, this work group session is being recorded, and we will provide the slides and that recording to you in the follow-up email. Just give me a little bit of time to pull all of those materials together for you. You will receive them before the end of the day. Second, a reminder to please double check that your mic is muted throughout the presentation. I believe I caught everyone that came in from the waiting room. But please please double check that you are muted to reduce that background noise, unless you are unmuting to ask a question, then by all means. And then finally, for questions, we're going to be monitoring the chat throughout the presentation, and then we'll have dedicated Q&A session after both of our presenters have completed their presentations. Right. Lastly, for those attending this work group for P4P credit, we look forward to your active participation throughout the work group. This might include responding to polls, discussion questions, and asking any questions that you may have during the Q&A session. We will also be sharing that post-work group survey, which is required to be completed for credit for attendance to today's work group at the end of today's presentations. It will also be sent in our follow-up email. For hospitals participating in MVC's P4P program who would like to receive credit, like I mentioned, that survey is mandatory, and you must note the hospital that you would like to receive credit for your attendance within that survey. Okay. So today's presentation is going to include two presenters. First will be Nicole Mott. She is a general surgery resident at the University of Colorado in her 4th year of residency and in the 2nd year of a dedicated research time. She's a scholar in health policy and health services research through the National Clinician Scholars Program at the University of Michigan, and is also a fellow with the Costs of Care organization. Broadly, her research interests are in evaluating and improving the value and quality of healthcare through policy evaluation, quality improvement, and the dissemination and implementation science approaches. More specifically, her current research explores insurance design, medical debt policy, financial toxicity, quality measurement models, and the de-implementation of low-value care. Her clinical interests are specifically in thoracic surgery. And then we will also have a short presentation from Kelly Lewton. Kelly is the Performance Improvement Coordinator for Lake Huron Medical Center and very graciously offered to provide some insight into her site's engagement with RITE-Size. Okay, without further ado, I'm going to turn it over to Nicole. Nicole, you should have remote control of my screen now.
Great. Thank you so much. And thank you for the introduction. Definitely don't need to repeat any of that. But my name is Nicole, and I've been working on the RITE-Size initiative along with our project manager, Dana Green, who's on the phone call. Or Zoom call, I should say. So you may have gotten emails from him or heard from him in different settings. But we're really excited to talk to you today about RITE-Size, which stands for Right Sizing Testing Before Elective Surgery. So I'm sure that some of you on this phone call are already familiar with the motivation for this work, but I'm just kind of going to go through it briefly to get us all on the same page. Unnecessary preoperative testing in otherwise healthy patients before low-risk surgery can lead to several downstream consequences. These include increased costs. There we go. And increased costs are not just from the perspective of the healthcare system, but it's also from the perspective of patients who often have to pay out of pocket for some of these preoperative tests through copays or coinsurance. It also can lead to care cascades or a series of tests and procedures that are stemming from incidental findings that we never would have gone looking for anyways, and that don't really impact the patient or their care. And ultimately, these things lead to treatment delays. So, in this setting, there have been multiple national and international guidelines that recommend against routine preoperative testing in otherwise healthy patients before low risk surgery. These are multidisciplinary guidelines, so they're not just surgery guidelines, but they also come from anesthesiology societies and general internal medicine societies. Unfortunately, despite all of these guidelines, unnecessary preoperative testing still remains pretty common and widespread. So, in this setting, we designed an intervention locally at Michigan Medicine to reduce unnecessary preoperative testing. It was a multi-component deimplementation intervention. And so, multi-component just refers to the fact that it had multiple different arms to try and reduce unnecessary preoperative testing. So, this included a site visit in which we talked to stakeholders, surgeons, anesthesiologists, preoperative nurses, quality leads. It involves educational interventions such as a decision aid. It involves going over workflow processes such as anesthesia protocols or electronic health record mechanisms that may prompt or promote unnecessary preoperative testing. And then it also involves auditing and feedback of data so we can get sites their preoperative testing rates and see how they're doing over time. And that's where we partner with MVC as well as MSQC on all this work. So we piloted this at Michigan Medicine for 3 common elective surgical procedures: cholecystectomy or gallbladder removal, hernia repair, and breast lumpectomy. And you can see in the post-intervention period on the right side of this graph, the unnecessary testing rates were lower as compared to a pre-intervention and intervention period. So after we saw that this worked at our hospital system, we wanted to expand it to other hospitals in the state of Michigan. And so we just did just that at 3 pilot sites. And I'm going to be talking a little bit about those results. So we did this pilot study at 3 hospitals in Michigan from March to August 2024. And our primary outcome was just to see, is it feasible? Because sometimes when you have an intervention that works at one hospital, as I'm sure you're all well aware, it doesn't always translate well to other hospitals because they have different priorities, stakeholders, and workflows. And so we wanted to see if it was feasible to implement RITE-Size at these additional pilot sites. We were also interested in determining if we could decrease unnecessary testing rates, if people like the intervention. So acceptability and appropriateness are kind of these fancy implementation science measures that we use to basically determine if the stakeholders like the intervention, they think it works, and they're going to continue using it. And then finally, we wanted to determine the barriers and facilitators. So what makes it challenging to reduce unnecessary preoperative testing and what makes it a little bit easier at these different hospital sites. So in terms of feasibility, we were happy to see that the RITE-Size intervention did work at these additional pilot sites, and all of our milestones that we set for implementing RITE-Size were met on time. In terms of testing rates, we were pleased to see that there was a significant reduction in unnecessary preoperative testing. So across all the sites, testing rates went down by 28% in the last 2 months as compared to the first 2 months. And then finally, as I was mentioning, oops, Emily, do you mind going back one? Thank you. As I was mentioning, the intervention was liked by people based on these acceptability and appropriateness measures. So there are scales out of 20, and you can see the median score was 20 out of 20 for both of those. Okay. I think I lost remote control, but you can just go to the next slide. And this graph is just showing those testing rates in a little bit more detail. And so the green line is the average across all three sites. And you can see it was about 68% in the first 2 months as compared to about 40% in the last 2 months. You can also see in this graph, there's a little bit of variation from site to site. It's also not a steep, steady decline month to month. There is a little bit of variability. Some of that is attributable to case volume or how many procedures were done that month, but um, kind of ongoing progress is needed even after some initial improvements in order to sustain change. Okay, you can go to the next slide, please. So in terms of what made it challenging to implement RITE-Size or more broadly, just to reduce unnecessary preoperative testing, sometimes there's a little bit of confusion around the guidelines. So essentially, the guideline is that you don't need routine preoperative testing in otherwise healthy patients. Sometimes the measure of a healthy patient is based on the ASA class, which is something that anesthesiologists assign. And so sometimes that can get a little confusing or interfere with the normal preoperative workflow. There's also a need for ongoing education. Oftentimes, getting testing is ingrained behavior just because we're so used to doing it, or it's been part of an existing protocol for so long, or maybe there's staffing turnover. And so new people come in, or they're working in different departments and just need to be reminded of the need or lack thereof for preoperative testing. And then finally, it can be difficult to coordinate across a large healthcare system, as I'm sure some of you have experienced in your lines of work, just getting everybody on the same page. Go ahead and do next, please. So this is a quote from one of our participants in the pilot that speaks to some of these things. After changing the algorithm, the main hurdle was implementing it with the pre-surgical testing nurses because they're so used to doing things one way. It's just a habit. In a way, they're not even really looking at the algorithm. So that's just to illustrate some of those points I was talking about. On the next slide, we'll talk about some of the facilitators or what helped to implement RITE-Size or reduce unnecessary preoperative testing. So having key stakeholders is really important. For example, if there's a head anesthesiologist, surgeon, or nurse, or quality lead who's really motivated to make these changes and has the resources and authority to do so, that of course makes it easier and quicker to reduce unnecessary preoperative testing. Another big thing is the self-monitoring. So sites really like to get their feedback on how they're doing with testing rates, not only at their own hospital, but also benchmark to peer institutions so they can see if they're testing more or less or the same as other hospitals. And then finally, having strong team cohesion and communication to get everybody on the same page helps. So there's another quote here. Being that we're such a small facility and a small group, it's been an easier transition for us than some of the bigger facilities. We were able to get together, brainstorm, and work through things more than others. So on this next slide, we just have some additional quotes from our participants who participated in this pilot. And I summarized the main themes in the previous two slides in representative quotes, but you can see there's kind of a range of different perspectives here that speak to all these things. And I won't go through all these quotes right now, but they exist. So we are really happy with how the pilot went, and we're now in the process of expanding to additional sites. If anybody on this call is interested in participating and may, meet the criteria for participation based on testing rates, please reach out to Dana Green. We're looking for more sites to join us. And I just want to thank the team. Like I said, it's a very large team that we work with. So Dana Green is our project manager. Our principal investigators are kind of the lead in charge of the study design are Leslie Dossett and Hari Nathan. And then we work with a bunch of different organizations. So MVC, of course, also the Michigan Surgical Quality Collaborative, the Michigan Program on Value Enhancement, and the Institute for Healthcare Policy and Innovation. And then this last slide here just has the paper with our results from the pilot study if anybody is interested in looking into it in more detail. And I'm happy to take any questions when the time comes for that.
I'll just note that we can link that article in the follow-up email. So for anyone who would ask for that, I can definitely ensure that that is linked.
Great.
I had to re-sign in everything.
All right. So next, we had planned to hear from Kelly. Thank you so much for your presentation, Nicole. Um, Kelly seems to be having some technical difficulties, and I'm not sure if she will be able to contribute today. So I think what we'll do is just move into questions and discussion for Nicole. So if anyone has any questions and would like to unmute themselves or put those questions into the chat, we'll take a couple minutes to compose those.
Hi, Nicole. This is Joe Wajeska from UMH West. I was just curious, could you just elaborate a little bit more on, what interventions you thought were most impactful and like some, just a little bit more of the
Yeah.
detail around that?
Yeah, so I think the educational interventions, and we don't want to prescribe to the individual hospitals how they should educate their team members. So having really good team members that are like flexible and adapt our educational resources to meet their local environment is important. But the main educational resource we use is a decision aid that kind of helps perhaps preoperative testing nurses go through a workflow that might be different than what had been their workflow previously. The other thing that's really important is that auditing and feedback component. And so getting the data to see how the site is doing on their preoperative testing. The sites are really motivated by seeing the testing rates go down and then also seeing how their testing rates may compare to other hospital sites to motivate change because most hospital sites want to be on par with their peer institutions. I think those things have been the most effective in helping. Dana, do you have any other thoughts?
Nothing to add, Nicole, outside of what you said. I do really think that the audit and feedback piece was really huge, particularly when it came to giving specific feedback to surgeons regarding testing, because I think a lot of the questions that first are asked is, well, where is all of this testing coming from? And depending on, how your EMR system operates, like a surgeon could be accredited with having like a test assigned to them as like ordered it, but it's actually coming from the pre-anesthesia nurses. So just being able to track that and then be able to provide the feedback in a way that's effective proved to be really influential as well.
Great. Thank you so much for that question, Joe. Okay. I am curious if is anyone else on the call aware if their site has been engaged with RITE-Size, and if so, would anyone be willing to kind of talk about their experience with thinking about or integrating reduced unnecessary pre-op testing?
It's Susanna from Hickman, ProMedica Hickman. I would be happy just to share. We were one of the hospitals in 2024, and I just want to start by saying that Dana Green and the team were fabulous to work with, very accommodating and supportive. One of our biggest, I think, one of our biggest uh, activities that led to success was just really taking a look at those cases that had the inappropriate pre-op testing to see why. Why, why was that ordered? And a lot of them were things we couldn't change at our hospital. For example, we can get patients on the surgery schedule fairly quick in less than 30 days. So if a patient was seen by the primary care provider and testing was ordered, that fell into that 30-day window, even though it was appropriately ordered for other reasons, not for the purpose of the surgery. Um, what were the other questions you were asking? I'm sorry.
Oh, that's okay. I was just looking for, a little bit of insight as to your experience, which I think you provided, and if you have any other thoughts with regards to, kind of how reducing pre-op testing at your site is going. You mentioned that you were enrolled with RITE-Size a little while back. So how has it gone over the last year or two? Have you continued to see
Yes.
a change in your processes?
Yes, what we implemented in 2024, we've carried forward as part of our plan, and I've continued to abstract that data for MSQC and do see continued success and low testing rates, definitely under the targeted range. So, very, very, very well supported by our team here. So, yes,
That's lovely.
thank you.
Oh, thanks so much, Sienna. Looks like Kelly has been able to join us. Kelly, can you hear me?
I can. Can you hear me?
Yep, I can hear you. I'm gonna back up my slides. I know you joined us by phone, so are you able to see the slides that I'm sharing?
I can't,
Okay,
but I have my slides up. Everybody, I do
perfect.
apologize for the technical difficulties. We have a firewall block here, and it makes it impossible, nearly impossible, to do a lot of things. So I apologize.
Lovely. Well, Kelly, we were just having a discussion and hearing from a couple other sites that were on the call that have been involved with RITE-Size, and I'd love to have you give a little presentation on Lake Huron's experience thus far. So I currently have your title slide up on our screen.
Okay, I will start, and I will let you know when to move forward if you don't
Okay,
mind.
sounds good.
So I am Kelly Lewton. I joined the quality department at Lake Huron Medical Center about a year ago. We had actually started this project kickoff in January of 2023, so it's our third year working on third and final year on reducing pre-op testing in the low risk surgeries. You can go to the next slide, Emily.
Okay.
Thank you.
Mm-hmm.
So they had a kickoff meeting prior to me, of course, in December of 22. They kicked off the project in January of 23. And I came along in very end of October of 24. And I was brand new to quality. I didn't know much about it. And I struggled to even figure out the numerator and denominator and what it meant and what I was supposed to be doing. And so working through all of those nuances, we also spent the next year seeing where we had some outliers and where we could make some improvements. The previous quality nurse had been abstracting cases. However, I feel that she was abstracting sometimes not appropriately. Like, say the patient came into the ER 2 weeks before their scheduled surgery, but they came to the ER with a urinary tract infection, and our doctors drew all of this blood work just to make sure. And she would count those, and I learned those weren't to be counted. So I spent a few months trying to figure out what exactly was appropriate and what was not appropriate. And at the same time that I joined in October, we got a surgeon that was new to us, but not a new surgeon. And after watching for about 4 or 5 months until about April or May of this year, I noticed that he was ordering EKGs on anybody that was 50 years and older. And he was the only surgeon doing that. So after I was able to gather that information, we had RITE-Size come out and meet with us. And they had recognized that same pattern when I showed them the data of the EKGs. And so at our site visit, we had our director of anesthesia, our director of OR, and some other quality department team members. Our surgeon champion unfortunately couldn't make it, but RITE-Size brought their team members too, and we had a very active and engaging site visit. It was about an hour, maybe a little less, and everybody was actively engaged. Our anesthesiologist absolutely loved the recommendations that were given to us. She had spent a lot of time speaking with them and on behalf of trying to reduce the testing. So when she had learned about the newer position to us ordering these EKGs, she actually spoke to him that day after the meeting, and he had stopped ordering the EKGs. I had seen him the next day, and I had asked him about that, and he said, I was supplied those guidelines when I started here, and I don't want to order EKGs on anybody 50 and older because I don't think they necessarily need them. But that was the process I was provided. So with that, I learned that this was quite an easy fix, to be honest with you, because he didn't want to order them to begin with. So he ended up stopping those EKGs, which was one of our biggest outliers. Overall, we did learn, if you want to go to the next slide, Emily, you can. So overall, we did learn that we have pretty much we've made quite the improvement, and we have been following the guidelines that we had put in place starting in January of 2023. However, we were following them, and I believe it was based on the fact that we're a small community hospital and word of mouth was able to spread because this was never in writing. So in September, I had prior to September, I had requested to see how we ordered labs and who got labs and who didn't get labs. So I met with pre-op testing and I met with our director of anesthesia. In September, I was provided a 3 to 4 page document of typed up guidelines that were probably typed in the 80s. The font is really that old, with so many handwritten notations that I told the pre-op testing nurse that if I started new today and you handed this to me, I would quit because there was no way to follow it. So we all met in September, and we got that all in alignment with what we would like to see ordered, what needs to be ordered, following the guidelines of these 3 basic surgeries. So the hernia repair under 3 centimeters, the lap choles, and the lumpectomies. Now our doctor, our anesthesiologist, is trying to spread that out further. She doesn't want to do it on just those cases, but that was our baseline, and that's where we started. So that's where we are drafting up the pre-op testing protocol, which we went over. I have not had an opportunity to type that up yet, but that is on my to-do list hopefully for this week. We also had our accreditation in November, so I was a little tied up with that. But it's been a great process. They have these wonderful resources to give to you with the RITE-Size program. They will come here, they'll visit with you, they will guide you, and they will tell you, you don't have to do any of this. You can take what you want, bits and pieces, and piece together your own plan to decrease. That is strictly recommendations, and it's just been a wonderful, wonderful experience for us here. You can go to the last slide, Emily. So Dana from RITE-Size and we laugh because of the typed up 1980s font. So what RITE-Size helped us do was step into the 21st century with our guidelines. We learned more about our pre-op testing guidelines and the fact that they were old and handwritten on and difficult to follow. So they did help us put that together. Again, they have a ton of resources to offer us. They have a website that has so many things on it. I didn't even get an opportunity to go through all of the website. And then they have the coaching staff using evidence-based research, which is what I really liked, because with the evidence-based research, you have proof right there, and it's easier to back up what you're saying when you have the proof there, as opposed to saying something and somebody trying to, what's the word I'm looking for? Challenge you on that. So that's it. I think I rambled a little bit. I'm sorry. A little nervous being on the phone. Does anyone have any questions?
That was great, Kelly. Thank you so much.
Thank
Yeah,
you.
so we've kind of started our discussion, and thank you so much for providing your insight, Kelly, and your experience thus far with RITE-Size. Does anyone on the call have any particular questions for Kelly, maybe specifically related to, her more recent experience with working with RITE-Size and reducing preoperative testing? Keep my eye on the chat as well if you would rather not unmute, but type in a question. Looks like Brooke did message us that Henry Ford Genesis is planning to start with RITE-Size in the new year. So that'll be a great opportunity. Okay.
Medica Monroe, can you guys hear me?
We can hear you, Laura. Yep.
Okay, wonderful. I just want to say that I have had the pleasure of working with Dana and the team, and also Susanna and Kelly. And I just wanted to say that we had started the protocol based on the recommendations in 2023. And 2025, we had the team come out to Monroe. And I just want to say how valuable that site visit was, because we were working on instituting the protocol, but there was still maybe some lack of cohesiveness with everybody in the anesthesia department agreeing or, valuing some of the points in the protocol, and having that team come in and giving the providers the opportunity to ask questions to somebody to get that real time face-to-face conversation. That was invaluable. And after that, there has been no further pushback or conversation where anyone's questioning things. And it has run really smoothly since then. So I just wanted to say thank you to the team, and to anybody who's considering working with them, I would highly recommend it.
Thanks so much, Laura.
Yeah, Emily, if I could jump in really quick, I would even like to add, in Laura's case, because I knew that she had been working with Susanna, and we had essentially been tracking their progress, since they kind of started in 2023. We're working to reduce preoperative test rates. After that initial site visit, I believe we had um, one or two implementation coaching sessions, and we could tell that they were already, on the right path, and had to make a couple of small tweaks. But it was actually our recommendation that one said that they had, appropriate buy-in, that they had already implemented enough strategies to see sustained success. So I'm happy to see that things are continuing to go well with Laura over there at ProMedica Monroe. And similar to what Kelly was saying earlier, is that one of the great things about RITE-Size is that they are recommendations, and that we do ask to participate in a certain number of implementation coaching sessions, the max being 4. But if we, after the initial site visit and the first 2 coaching sessions, if we determine hey, your site is already in a great place, you've implemented, decision aids, or you've already updated the anesthesia guidelines, at that point, it's more of a learning experience for us, and we continue to track your site and your testing rates. But then at that point, we're really looking for hey, tell us about, what worked at your hospital versus what didn't. And, how would you recommend other hospitals adopt these strategies in the future? So the great thing about this initiative is that it's both a research study and a quality improvement project. So we benefit from getting the insight from hospitals who have been able to do this successfully. And then we help hospitals who haven't been able to do it successfully or like to see more be done.
Mm-hmm. Great. Thanks so much, Dana. I would just call out if there's anyone on the call today that, sort of new to this conversation, just a reminder that Your pre-op testing rates and some additional information is available on MVC's data registry. We have some pretty advanced multi-payer reports available on there for you to review if you were questioning, where your site is even kind of falling. Jenny, you've got your hand raised. Feel free to unmute
Hi, hi.
yourself.
Oh, sure. Can you hear me now?
Yes.
Okay, very good. Nice to see everyone. In Saginaw, when we were still under the Ascension umbrella back in 2023, we successfully reduced our pre-op testing by using a simple decision tree. I think that's what Dr. Mott was talking about. And our very first step was deciding, who's the decision maker? Are the surgeons going to order pre-op testing, or does anesthesia want to own this? And part of our success was that anesthesia was glad to own it. So while, they're both stakeholders, we had one person driving or one group driving. And so, we're going to take a look at where we are with our data, et cetera, and see if we can do a refresh because we have a lot of new stakeholders. So my question is, what do you see across the collaborative? Is it more surgeon driven or anesthesia driven for testing frequency, or do you understand my question? Is there a trend?
I think I'll just speak to our experience with RITE-Size. I think it really depends on the hospital. I think a lot of times it's driven by anesthesiology. However, that's not always the case. And sometimes there can be an outlying clinician. And so, like we heard in that previous example, wasn't that surgery as a department or a surgical head was leading the preoperative testing, but there was one particular surgeon who was using the wrong protocol that was new to the institution. So sometimes there can be outlying clinicians regardless of their specialty. Another thing is who's making the decisions versus who is carrying out the testing on the ground. And sometimes those two groups don't talk to each other. So sometimes it might be technically the anesthesia department that's coming up with these protocols and making the decisions. But if the preoperative testing nurses on the ground who are physically responsible for ordering the tests are doing their own thing or maybe using a different protocol, then there's some disconnect there. And that's frequently what we see. And so through our site visits and our conversations, implementation coaching sessions, and targeted auditing and feedback, we try to track down the root cause analysis. And so that's at least been our experience with the hospital sites that we've worked at.
Great. That all makes sense. Thank you.
Thanks so much, Jenny. Okay. Any last questions or comments? Okay. Just going to go ahead and finish up with some MVC updates. Just to call out, we have one last work group before the end of 2025. It's going to be our Health in Action work group on December 18th. So if you're looking for a last minute 0.1 P for P points, we look forward to seeing you on the 18th. We're going to be doing sort of a look back at what's been accomplished in 2025 and looking forward to what your goals are for QI in 2026. So we're hoping it will be a really lively, more discussion-based work group with opportunities to break into small groups to discuss those things. And then starting in January, our first work group of 2026 will be our sepsis work group on January 13th. So we'll see you in the new year. All right. Additionally, just wanted to call out that we are currently collecting requests for site visits in 2026, as well as presentation proposals for 2026. So if you are interested in having an in-depth conversation with MVC, please consider scheduling a site visit with us, either virtual or in person. And if you have a QI project that you'd like to talk about a little bit more, we are also seeking presenters for our work groups and collaborative-wide meetings in 2026. All right, and lastly, I will call out, it looks like my bullet point didn't save here, but coming out this afternoon, registration is opening for MVC's new Site Coordinator Education Program. You might have seen an email from me last week about that. So if you are a site coordinator with MVC, you will be receiving that registration opening email shortly, and I look forward to engaging with you. All right, that concludes our preoperative testing work group. We'll have the link for the post-meeting survey in the chat here shortly. And we'll give you a couple of minutes to grab that. If you are calling in and unable to access the chat, that will be included in our follow-up email. And thank you again to Nicole and Kelly for presenting today, and Dana as well for contributing. Hope you have a nice day.
Thank you.
Thanks, Emily. Thank you, everyone. Have
Thanks
a
for
good
having
day.
me.
Thank you, everyone.